So, in our last explainer, we talked about the eligibility problem. But today, we're diving into a real paradox. For years, India's health claims system had this strange contradiction. Almost every organization had gone digital, they'd invested in technology, and yet the entire process was still painfully manual. Why was that?
Here's how we're going to break it down. First, we'll look at why all this digitization created an illusion of progress. Then, we'll get into the two real culprits, the data disconnect and the communication maze. We'll see how this created an automation ceiling, and finally, how a network-level solution was the only way forward.
And this is really the central question, isn't it? It just didn't make sense on the surface. Everyone had the tech, everyone was digital. So why did the system as a whole still feel so completely broken? Well, it turns out the answer was less about the technology itself and more about how everything was connected, or rather, not connected.
All right, let's start with what looked like progress but really wasn't. The story of this failure actually begins with a lot of well-intentioned decisions. The problem was each organization was solving for itself, which ended up creating a much bigger problem for the whole system.
You see, money was being poured into tech everywhere. Hospitals were buying these sophisticated management systems. Insurers were launching slick, modern online portals. And yet, when you looked at the big picture, the actual outcomes didn't change. The claims process was still slow, costs were still high, and it was a headache for everyone involved. What actually happened was that each organization built its own highly efficient digital silo. Think of them as beautiful, modern islands. On the inside, they worked perfectly, but they were completely cut off from each other. They simply weren't designed to talk to the outside world. So, in effect, the system just traded one kind of paperwork for another. We went from stacks of physical paper to folders full of digital files, like PDFs and online forms. The core inefficiency of the process wasn't fixed at all. It was just given a modern coat of paint. And you can just imagine what this meant for the people doing the work. Instead of making their lives easier, technology actually created a new, very tedious kind of manual labor. Hospital staff had to sit and copy-paste the exact same patient data into 10, maybe 15 different insurer portals, each with its own layout and rules. It was inefficient, prone to errors, and just completely unscalable. So this brings us to the obvious question. Why couldn't these digital islands just talk to each other? Well, the first part of the diagnosis has to do with the data itself. The very language of healthcare information was completely fragmented. The main issue wasn't a lack of data, it was the lack of a common language. A hospital system might record a diagnosis using one code, but the insurer system was expecting a totally different one. Essentially, they were all speaking different dialects, which made any kind of automated conversation impossible. And this is why simply converting paper forms into PDFs was not a solution. To a computer, a PDF is basically just a picture of text. All the critical information is locked inside that picture. It's unstructured data. A human still has to manually read it and enter it into a system. This is where something called data standards becomes absolutely crucial. Think of protocols like FHIR or ICD-10 as a universal translator for healthcare. They provide a shared dictionary, a common grammar, so that a diagnosis means the exact same thing to a system in a hospital in Delhi and an insurer's system in Mumbai. This is what allows different systems to finally speak the same language. But okay, even if everyone spoke the same language, there was another huge obstacle. The way organizations were connected to each other, the network itself, was a complete mess. The old model was basically a tangled web. For a hospital to submit claims, it had to build a separate, custom digital connection to every single insurer it worked with. This was incredibly expensive to build, a nightmare to maintain, and technically very fragile. And for smaller hospitals, it was simply out of reach. Now, NHCX completely changes this with a very simple and elegant hub-and-spoke model. Think of it like a central post office. Instead of building hundreds of private roads, a hospital just needs to build one road, one single connection to the NHCX gateway. NHCX then securely handles the delivery to every other player on the network. And the impact of this is huge. This one move drastically lowers the cost and complexity for everyone. It removes all those old barriers, which means, for the first time, even smaller hospitals and new technology companies can easily plug into a national digital ecosystem. So let's go back to those organizations that spent millions trying to perfect their own internal systems. All that investment could only get them so far. They eventually hit a hard wall. A hospital could have the most efficient internal processes in the world, like a Formula One race car, perfectly tuned. But the moment a claim had to be sent out into the fragmented ecosystem, it was like putting that race car onto a bumpy, broken village road. All that internal speed and efficiency just vanished. And this is exactly what we call the automation ceiling. You can see it here. Internally, a hospital might be operating at 90% efficiency. But the moment that claim leaves, it enters an ecosystem that's only 20% efficient. So all those internal gains are immediately wiped out.
And this gets to a very fundamental principle. You cannot solve a network problem by just optimizing a single part of it. It's like trying to fix a citywide traffic jam by making just one car go faster. It just doesn't work. You have to fix the roads for everyone.
And arriving at this understanding was the real breakthrough. It meant reframing the entire problem. The solution wasn't about building better individual systems. It was about building a modern public highway for the entire ecosystem to use.
Because when you really look at it, the persistent problems in health claims were never about a lack of technology. The tech was always there. The real issue was a failure of vision. The core problem was the deep fragmentation of the ecosystem itself. Everyone was so busy perfecting their own little island that no one was taking responsibility for building the bridges between them.
And that is precisely the role of NHCX. It is the bridge builder. It's not just another app or another portal. It's a piece of shared national digital infrastructure, like a power grid or a highway system, designed to connect all the islands into one seamless network. The story of India's health claims journey is a powerful reminder that having good technology is never enough on its own. We also need to have the collective vision to build these shared platforms that allow that technology to reach its true potential. And it leaves us with a bigger question to think about. What other complex challenges in our country could be solved if we stopped just building islands and started building bridges?